Let's review another interesting case today. Our patient is a 4-year-old child with a rapidly enlarging mass in the right thigh. Imaging showed invasion into the femur. A biopsy performed at an outside hospital was diagnosed as epithelial sarcoma, and the child received neoadjuvant therapy before coming to our institution for amputation.
Here is a picture of the resected mass. We see sheets of tumor cells with islands of squamous keratinization. At higher magnification, the squamous nests are evident, and the background cells show angulated pleomorphic nuclei. However, there is no mitotic activity and no necrosis. This second image shows the same tumor with squamous islands and background pleomorphism, cells that look malignant but again without mitoses or necrosis. Immunohistochemical studies demonstrated diffuse positivity for squamous markers, P40, P63, and CK56. All other tested markers, including S100, SOX10, desmin, myogenin, CD99, CD34, and many others, were negative. Morphologically, the tumor has squamous differentiation. Immunohistochemically, it stains like squamous cell carcinoma. But diagnosing squamous cell carcinoma in a 4-year-old did not make clinical sense. The outside diagnosis of epithelial sarcoma also was confusing, since no such diagnostic entity exists. Because the original slides were not available, the rationale behind that diagnosis was unclear.
Given the abrupt squamous differentiation, our differential diagnoses included NUT carcinoma, adentomoma like Ewing sarcoma, and adentomoma. NUT carcinoma is typically a high-grade aggressive tumor composed of undifferentiated monomorphic cells with brisk mitotic activity and necrosis, features not present in our case. Ewing sarcoma was ruled out when CD99 returned negative. Adentomoma was unlikely due to tumor location, aggressive growth on imaging finding, and degree of atypia. So what else could this be? This case was genuinely confusing, and we performed more immunostains than we would like to admit. Eventually, the answer turned out to be hiding in plain sight. We revisited the possibility of NUT carcinoma, which had initially been dismissed due to the not high-grade morphology.
Here is the NUT immunostain, diffusely positive in tumor cell nuclei.
Given the unusual morphology and clinical history, we proceeded with NGS, which confirmed NUT carcinoma. The atypical, deceptively mature appearance was a treatment effect. Chemoradiation can induce tumor maturation and suppress mitotic activity. Unfortunately, the patient developed a pelvic recurrence 1 year after surgery. Here is the true morphology of NUT carcinoma at recurrence: large areas of necrosis, brisk mitotic activity, and a high-grade monomorphic population of cells with prominent nucleoli and undifferentiated morphology. The differential based on morphology only would include carcinoma, sarcoma, melanoma, and lymphoma. Numerous apoptotic bodies and mitoses are present. NUT carcinoma is defined by NUTM1 gene rearrangement, most commonly with BRD4, BRD3, or NSD3. NUTM1 rearrangements also occur in some sarcomas and leukemias, but with different fusion partners. Morphologically, NUT carcinoma falls into 2 categories: poorly differentiated carcinoma with no clear lineage, and poorly differentiated squamous cell carcinoma, often with abrupt keratinization. Squamous differentiation is seen in about 1/3 of cases. NUT carcinoma most frequently arises in the lungs and head and neck region, about 90%, but the remaining 10% occur at various other sites, including soft tissue, bladder, GI tract, and so on. It predominantly affects children and young adults, with a median age of 24 years, though cases range from infancy to 82 years. The prognosis is dismal, with a median survival of 6.5 months.
tumors are consistently positive for P63 and CK56, and less frequently P40. Recent literature even suggests categorizing NUT carcinoma as a molecular subtype of squamous cell carcinoma. Importantly, NUT immunostaining is both sensitive and specific. Diffuse strong nuclear staining in more than 50% of tumor cells provides nearly 100% sensitivity and up to 90% specificity. Molecular confirmation is usually unnecessary when IHC is strongly positive.
Our next case is a 29-year-old man with a rapidly enlarging thyroid mass.
At low magnification, we see residual benign thyroid tissue in the right lower corner and an invasive tumor occupying most of the gland. High-power examination shows a high-grade undifferentiated neoplasm with high NC ratio, monomorphic nuclei, and prominent nucleoli. As with the prior case, the differential diagnosis includes carcinoma, sarcoma, melanoma, and lymphoma. Here we see the infiltrative edge, with irregular nests of tumor cells. Some areas show squamous differentiation with abrupt keratinization, a hallmark feature. Multiple neck lymph nodes contained metastatic deposits composed of undifferentiated tumor cells. The tumor stained positive for P63, P40, and CK56, and was diffusely positive for NUT. This is another example of NUT carcinoma, this time arising in the thyroid. It is estimated that roughly 1,400 cases of NUT carcinoma occur annually in the United States, about 7 times more common than Ewing sarcoma. Yet many clinicians perceive it as extremely rare and almost non-existent due to underdiagnosis and misclassification. This lack of recognition has slowed progress in research and treatment. As pathologists, we play a critical role. Whenever we encounter an undifferentiated carcinoma or a poorly differentiated squamous cell carcinoma that is positive for squamous markers, we must consider the possibility of NUT carcinoma. Summary: NUT carcinoma is a poorly differentiated carcinoma defined by NUT1 gene rearrangement. Squamous differentiation, either morphologically as abrupt keratinization, or via immunostains, P63 and CK56 is present in all cases. It presents as a high-grade blue cell tumor and should be in the differential when evaluating undifferentiated or poorly differentiated squamous lesions in children and young adults. Prognosis is extremely poor, with a median survival of 6.5 months. Accurate diagnosis is essential to raise awareness, drive research, and ultimately improve treatment options for this aggressive disease.